Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse, as well as CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. We would like to thank our following partners for supporting today's webinar. At this time, I would like to introduce our moderator, Dr. Brian Kaufman, who is CLL Society's Executive Vice President and Chief Medical Officer.
Thank you, Robin. I would like to welcome our audience and speaker to today's event. We are joined by world-renowned CLL expert physician, Dr. Matthew Davids, member of our Medical Advisory Board and Associate Director for the Center of Chronic Lymphocytic Leukemia at Dana Farber Cancer Institute in Boston, Massachusetts. Dr. Davids is going to discuss with us Bruton tyrosine kinase inhibitors, also known as BTK inhibitors. These are the targeted therapies that revolutionized CLL treatment when they first came out and continue to play a critical role for treating CLL patients. And we're also going to be discussing new BTK options that are becoming available. As some of you may know, I participated in a very early trial of what at that time only had letters and numbers, PCI 32765. Which is now known as ibrutinib, which is one of the reasons that I'm healthy and well and able to be with you today. Before we begin, we have 3 brief poll questions that you'll find on your screen. Please scroll down, and you're going to have to scroll quite a bit down here to see all 3 questions. Question 1. What areas have you researched regarding BTK or Bruton tyrosine kinase inhibitor therapies, and select all that apply? 1, length of time the product was on the market, summary of clinical trials, side effects or adverse events, educational resources available to patients and caregivers. I learned about my treatment from my hematologist oncologist are not applicable. Question 2, so scroll down. After speaking to your hematologist oncologist, did you end up going on one of the BTK inhibitor treatments you researched? Yes, no. I learned about my treatment from my hematologist oncologist. I'm on watch and wait, or not applicable. Question 3. Have you asked your hematologist oncologist for a particular BTK inhibitor by name? Yes, no. I learned about my treatment from my hematologist oncologist. I'm on watch and wait, or not applicable. Thank you for your participation. We would now like to welcome Dr. Matthew Davids to take us through this important targeted therapy for CLL, bring us some of the exciting original news and the even more exciting latest news on developments in BTK or Bruton tyrosine kinase inhibitors. Thank you.
Hello, everyone. My name is Matt Davids, and I'm the Associate Director of the CLL Center at Dana Farber Cancer Institute, as well as an Associate Professor of Medicine at Harvard Medical School here in Boston. And I'm very happy to be with you today to discuss the evolving role of BTK inhibitors in CLL. These are my disclosures. I do paid consulting work for most of the companies working in this space, and our institution also receives research funding from these companies. So 4 main learning objectives today. First, what are BTK inhibitors? Second, what is their role in CLL therapy today? Third, how do they compare with each other and other treatment options? And finally, what roles might they play in the future? So I wanted to give a brief introduction for those of you who may not be as familiar with BTK inhibitors. And I really like to start by highlighting that we now have a diverse array of mechanistically diverse targeted therapies for CLL treatment. So what do I mean by that? This little cartoon involves a number of different molecules and pathways, but really what I want you to focus on is the fact that you have a big CLL cell there that doesn't exist in isolation, but rather it exists in what we call the stromal microenvironment, where a CLL cell can interact with a number of other different types of immune cells. And these immune cells are constantly sending signals into the CLL cell that foster its division and proliferation. In other words, keeping it alive and keeping it happy. And so all these different drugs that you see listed here, some of which you may be familiar with, the idea is to interrupt those survival signals, to really cut the CLL cells off from the microenvironment. And CLL cells don't like that. So when they're cut off from their survival signals, they tend to die over time. And that's really the goal of these therapies, is to kill the CLL cells to get patients into remission and feeling better. And so we're focusing today on BTK inhibitors. BTK is a protein you can kind of see in the middle there that is in a pathway called the B cell receptor signaling pathway. And this is really one of the key pathways that keeps the cells alive. And so you can interrupt that pathway by blocking the BTK protein. And we'll talk about the drugs ibrutinib, acalabrutinib, and zanubrutinib, which can all do that. And then you can see that there's a number of other pathways that can be targeted, and some of these drug names might be familiar to you. We're not going to talk as much about those today, but I do like to highlight that we have lots of good treatment options for patients with CLL. And I also will highlight that none of the options on this slide are chemotherapy based, because we're really not having to use that too much these days to treat patients with CLL. And that's really because of some of these milestones in clinical research in CLL that have occurred over the last several decades. You can see just even visually in this timeline that going back to the 50s and 60s, there was some early work in CLL clinical research, but really not too much was accomplished during that era. Even into the year 2000 or so, really all we had was kind of single chemotherapy drugs that had some activity, but really didn't really help that many patients for a long period of time. Now, in the 2000s, there was a regimen developed called FCR, where 3 different drugs were put together, 2 chemotherapy drugs and 1 immunotherapy drug, rituximab. And FCR did improve the overall survival for patients with CLL. So that was a big innovation back in 2010, which coincidentally was right around when I started getting focused in this field. But it was clear early on that FCR was a difficult regimen to tolerate for a lot of our older CLL patients. And even for younger patients, there were some significant risks of infections and even a higher risk of developing other types of cancer later on. And so there was a lot of investment and interest in developing the targeted treatments, which target those pathways I just showed you in the CLL cell, but spare the other cells in the body. So unlike chemotherapy, they tend to have a better side effect profile and actually even be more effective. And so the first BTK inhibitor, ibrutinib, was FDA approved back in 2013 initially. And then soon thereafter, there was approvals of single drugs like idelalisib, which targets a different protein called PI3 kinase. And then in 2016, the approval of venetoclax. And then you can see over the last few years, there's been a number of large clinical trials which have compared the targeted treatments to the prior chemotherapy-based treatments. And trial after trial has shown benefit of the targeted therapies over chemotherapy. And this has really changed our approach to treatment of CLL just in the last few years. So now when I sit with patients and we try to decide about what frontline therapy to give, which means the first therapy for CLL, this is sort of the choice before us. It's a continuous treatment with one of the BTK inhibitor drugs, or what we call a time-limited treatment of 1 year of the venetoclax pills with obinutuzumab infusions. Now, on the positive side for the BTK inhibitors, they are very convenient because they're just pills. They don't require any kind of infusion. And we don't need to monitor patients' labs closely for something called tumor lysis syndrome, which is when the tumor cells can break open so quickly they can release toxins into the bloodstream. And that's something we see with venetoclax treatment. We have long-term data with BTK inhibitors. They've been around for nearly 10 years at this point, and they can work for a very long time when patients stay on the treatment. And we have a very high level of evidence, what we call phase 3 data, that compares BTK inhibitors to our standard chemotherapy regimens and shows superiority of the BTK inhibitors. We also have more data right now to understand how effective the venetoclax drug is when we start with the BTK inhibitors rather than the other way around, starting with venetoclax and using BTK inhibitors second. Although I would say that probably either order of using these drugs is going to be helpful for patients. Now, on the other hand, with venetoclax plus obinutuzumab, we do have a 1-year time-limited therapy. And I know for a lot of my patients, they really like the idea of just 1 year of therapy and being done for a while rather than having to take the BTK inhibitors year after year. Also, as you'll hear, the BTK inhibitor drugs do have some cardiovascular risks, especially for patients who already have cardiovascular disease or already need to be on blood thinner medicines for conditions like atrial fibrillation, whereas venetoclax-based treatment has no known cardiovascular or bleeding risks. It's easier, I think, for most patients to understand they just need to take the drugs for 1 year and they can stop. I do have some patients who start to maybe not keep up with taking the drugs as long, taking it daily for years and years at a time. It can be difficult to keep doing that. So less concern for long-term adherence. And at least at societal level, but maybe even at a patient level in terms of the copays that patients often have for these expensive drugs, there can be some cost savings if you do a 1-year therapy versus a therapy that requires several years of treatment. So those are some of the main considerations. So I also wanted to just highlight again that the BTK molecule here is right in the center of all these key pathways that are necessary for CLL cells to survive. And I'll mention that the drugs that we'll talk mostly about today, acalabrutinib, ibrutinib, and zanubrutinib, really they target that BTK very tightly. So once they stick onto it, they don't leave it. And that could be an advantage, but it can also be a disadvantage if that BTK eventually develops something called a resistance mutation where the drug can't attach as well to the BTK. So I will mention, I'm not going to talk as much about it today, but there's some newer drugs in development like pirtobrutinib and nemtabrutinib, which can still hit BTK, but they're non-covalent, meaning they don't stick onto it. They kind of bounce off and on it, and they don't really care if there's a resistance mutation there. So that's been a nice development in the field. Those drugs are not yet FDA approved, but we hope that they will eventually have a role in the disease. So how are these BTK inhibitor drugs different? Now remember, ibrutinib is the oldest of the drugs and has been around the longest. Acalabrutinib is a bit newer, and zanubrutinib is not actually yet approved for patients with CLL, although it's approved in other types of similar lymphomas, and we expect that it should get the approval for CLL very soon. And I like this way of representing the different drugs visually because each red circle here represents a different protein that's targeted by the drugs. So with ibrutinib, you can see a lot of big red circles. One of those is BTK, which is what we want to hit, but there's a number of what we call off-target effects, which are other protein targets that ibrutinib can target, which can lead to side effects. Acalabrutinib, as you can see, only has one big red circle. So that is BTK. There's a few other smaller off-target effects, but it's a very specific inhibitor. And then zanubrutinib is kind of somewhere in between, but I do tend to think of it as being closer to acalabrutinib than to ibrutinib in terms of the pattern of different proteins that it targets. So this was all kind of nice theoretical information before we had patients' data, but now we have the data in patients with these drugs. So does this really hold up? So let's review some of the data now. We have the 3 drugs here. You can see there's a number of different approved indications for the drugs, even outside of CLL, other types of lymphomas. Each of the drugs has a somewhat different dosing level and timing of dosing, but they're all oral drugs. They're all pills. And you can see some of the key side effects listed below that are in common between the drugs, things like risks of bleeding and atrial fibrillation, diarrhea, infection. But there are also some differences between these drugs that I will highlight. So first, let's talk about how effective the BTK inhibitor drugs are. So these are some early data from ibrutinib patients. This is one of the early studies, and we've now been able to follow these patients out for 8 years and see how they do on ibrutinib. And both in terms of what we call progression-free survival, which means patients are still free from progression of the CLL, they're still in remission, or overall survival, meaning are patients still alive. You can see both look very good in this population. Close to 85% of the patients are still progression-free and alive at 7 years. And I think this is pretty remarkable with a pill that you take once a day. This is really an amazing result. And so it's very reassuring that we have this type of long-term follow-up for ibrutinib. Now, a question often comes up of whether we should add one of the anti-CD20 antibodies to the BTK inhibitors. So remember, the CD20 antibodies are drugs like rituximab or obinutuzumab. These are given by infusion, so a little less convenient than the pills. But if they added something to the pills, I think most of the patients would be interested in it. And so we've been studying this for the last few years. And one thing that's been very clear is that when we add rituximab, one of the CD20 molecules, to ibrutinib, we don't really see much difference. The response rates are pretty similar in terms of how many patients have benefit, very high, regardless of what you do there. And that progression-free survival is essentially identical between these two approaches. So this has suggested to us that we don't need to add rituximab generally to ibrutinib. We can just treat patients with ibrutinib alone. But actually, which BTK inhibitor and which CD20 antibody may matter. And we're learning that through a study called ELEVATE-TN. And this is looking at a different BTK inhibitor, acalabrutinib, given with or without a different CD20 antibody, obinutuzumab. And actually, in this study, we are seeing some benefits to having the combination of acalabrutinib with obinutuzumab. You can see the response rates are higher with the combination, 94% versus 85%. And this 30-month progression-free survival is also a little bit higher, 90% versus 82% when you do the combination of the two versus the single drug alone. So I do discuss this with patients. You know, when you add the infusion, it's not as convenient. There are more side effects. And so whether it's beneficial to have a little bit longer progression-free survival given that trade-off, I think is not clear. And it's going to be an individualized discussion with each patient, but certainly something worth discussing. So these are the data from the ELEVATE-TN study, and we have 4-year follow-up here. We actually just recently saw a 5-year follow-up presented, which looks very similar. And on the left, you can see that both of the acalabrutinib containing regimens look very good. Very few CLL patients have had worsening of their disease during these 4 years. Certainly much better than obinutuzumab and chlorambucil, an older chemotherapy-based regimen that was the comparator in this study. Right now, there's no major differences in terms of the overall survival of patients, although over time, there does seem to be a little bit of widening between the acalabrutinib and the obinutuzumab chlorambucil. So probably, I think we will see patients living longer because of acalabrutinib in this context. And then the third BTK inhibitor is zanubrutinib. Remember, this is the one that's not yet approved in CLL, but certainly has very promising data and is likely to get approved soon. And that's mostly based on this study, which they nicknamed Sequoia. And this compared patients who had never received treatment for CLL before, given continuous treatment with zanubrutinib versus a 6-month course of chemotherapy with bendamustine and rituximab. And you can see on the left, the progression-free survival was much better for the patients who got zanubrutinib compared to chemoimmunotherapy. And that was particularly seen, as you see on the right, in patients who have the unmutated IGHV type of CLL. As you may know, CLL kind of has two main types, unmutated and mutated IGHV. And it's a little counterintuitive, but the patients with unmutated IGHV tend to have a more steadily progressive form of CLL that, at least with chemotherapy, did not tend to respond as well, compared to patients with mutated IGHV who had a better prognosis. But here, I think it's very reassuring for those patients with unmutated IGHV that the patients who got zanubrutinib seem to do just as well if they had unmutated IGHV as if they had mutated IGHV. So although historically with chemotherapy, this was an important factor in terms of the prognosis, it may be now that with the IGHV status, it's not as important for patients on BTK inhibitors, because this has been shown also with acalabrutinib and also with ibrutinib. And so it's a particularly helpful way to treat patients with unmutated IGHV CLL. Now, wouldn't it be nice if we could compare these drugs head to head? And in fact, actually we can. And there's a couple of big trials that have read out recently that I wanted to review with you that actually compared patients who had relapse CLL, meaning they had had prior treatments, and then they went on to a BTK inhibitor. And they were randomly selected to either go, in this study, on ibrutinib or acalabrutinib. And they continued the drugs until they had worsening of the CLL or bad side effects. But most patients were on these drugs for a long period of time. And very reassuringly, now with 3-4 years of follow-up here, you can see the curves are completely overlapping, meaning that whether you started with ibrutinib or whether you started with acalabrutinib, your CLL was controlled for just as long. But there were some significant improvements in the side effect profile of acalabrutinib compared to ibrutinib. And I tried to highlight some of the key ones here in bold in the table. So in terms of the risks of AFib, there was still some risk of AFib with acalabrutinib. About 9% of patients had this irregular heartbeat on the study, but that was compared to 16% of the patients treated with ibrutinib. Minor bleeding events are also quite common. This could include bruising, for example. That occurred in 38% of the patients on acalabrutinib compared to 51% of the patients on ibrutinib. So also better for acalabrutinib. Hypertension, which is high blood pressure, was about 9% in the patients on acalabrutinib compared to 23% of the patients on ibrutinib. And there were a variety of other differences between these drugs. There were a couple of things that were more common with acalabrutinib. So headaches were a bit more common with acalabrutinib compared to ibrutinib, and also some cough early on, but both of those tended to be very transient and got better fairly quickly. The other head-to-head study called Alpine is very similar idea, relapsed patients with CLL, and they received either zanubrutinib or ibrutinib. And here, the data are not as mature, meaning the patients haven't been treated for as long yet, because the study is still ongoing. So we've just kind of gotten some early looks at the data. And at least so far, it does seem like the patients on zanubrutinib have a little bit higher rate of having a benefit in terms of the response of the disease and that PFS. But I'll caution you that it's still very early here, and I think we need to see how these patients do in the longer term. I'd be surprised if there's a big difference in terms of how active the drugs are controlling the disease, but we'll need to follow that over time. But already what we can tell from the Alpine study is similar to what I showed you in the Elevate study with acalabrutinib. So here with zanubrutinib, again, much lower rates of cardiovascular issues, so 13% versus 25% with ibrutinib. Lower rate of atrial fibrillation. In this data set here, 2.5% of patients on zanubrutinib compared to 10% with ibrutinib. There is a little bit of a higher risk of neutropenia, which is low white blood cell count. Those are some of the key cells for infection fighting. So we do need to watch that. But if you look at the rates of infection, they're in the 60% range. And that can include things like colds and sinus infections. So it doesn't seem to be too much difference in infections between these two drugs. So there's a number of large studies ongoing right now that involve BTK inhibitors around the world. And I just try to highlight some of them here, not really so much to go into too much detail on them, but really just to give you a sense that there's a lot of ongoing work right now to understand sort of what are the best combinations of the BTK inhibitors. Do we need to give them in combination, or should we be giving them on their own? So a lot of these are randomized studies. Maybe two that I'll highlight here because they're still actively accruing new patients. So one is the CLL 17 study. That's the bottom one on the blue part. And this is going on in Europe. And it's comparing continuous ibrutinib treatment to two different venetoclax combinations, venetoclax with ibrutinib or venetoclax with obinutuzumab. So I think that's going to be helpful to understand how the continuous BTK treatment strategy compares to more of what we call the time-limited treatment with venetoclax. And then I'll also highlight at the very bottom a study that's going to be opening very soon here around the world called MAGIC, which is a study that I've helped to co-develop with Anthony Mato at Sloan Kettering and Jeff Sharman from US Oncology. And this is a study we've been working with AstraZeneca, AbbVie, and Genentech, so really bringing together a lot of the key people and collaborators in the field. And the idea is to try to understand how acalabrutinib and venetoclax compares to obinutuzumab and venetoclax. And our study uses something called MRD to guide the duration of therapy. MRD stands for minimal residual disease. And this is a way to detect very, very tiny amounts of CLL at a molecular level, even when you can't see anything under the microscope. And by using this, we hope that we'll be able to start to individualize the length of therapy for patients so that patients don't receive too much treatment if they don't need it, but the patients who do need a longer course of treatment will receive that extra therapy that they need. So please be on the lookout for that if you need CLL treatment soon and you've never had treatment before. We hope the study will be opening at sites around the world this fall. And if you're eligible, we'd encourage you to consider enrolling. All right, so I'm going to talk briefly about that other class of BTK inhibitor drugs because there's a lot of excitement around this. And these are the ones, remember, that are non-covalent, meaning they don't attach right onto BTK and get stuck for a long period of time. They kind of bounce on and off. And we think these are going to be important because if we look at patients who develop worsening CLL while they're on ibrutinib, about 56% will have a mutation just in that BTK protein that confers resistance, and another 16% will have a mutation in that and another target. And so this is really becoming one of the key reasons why patients do have worsening of their CLL while still on a BTK inhibitor. And so these are data for the drug called pirtobrutinib. And these were patients who had all had a prior BTK inhibitor like ibrutinib or acalabrutinib. and they were treated with pirtobrutinib, which is also a pill, given daily. And this is what we call a waterfall plot, where each of the bars going down represents a different patient on the study, and the degree of how far the bar goes down represents how much their lymph nodes shrank on the study. And the dark blue bars here represent patients who had previously had to come off of their other BTK inhibitor because their CLL was getting worse. The lighter blue bars are patients who came off because they had a side effect. And you can see, regardless of the reason for coming off the prior BTK inhibitor, most of the patients had a very dramatic reduction in their lymph node size. About 70% of patients had really a profound reduction that we would consider a true response to therapy. And for a group of patients who didn't have a lot of other good treatment options, I think this is really encouraging data. The other thing that's very exciting about pirtobrutinib is the safety profile of the drug. It looks to be very well tolerated. The different grading here represents the severity of toxicities. So what we call grade 3-4 side effects are pretty significant ones. And you can see the rates here are very low. Most of the grade 3-4 side effects are less than 1%. We do still see some neutropenia, that's that low infection fighting count, but we don't tend to see a lot of infections with this drug, and we can usually support patients to bring their neutrophil count up with drugs like GCSF. And so only 1% of the patients on this study had to come off pirtobrutinib due to side effects. And so I think it's very encouraging that this is a very effective drug, but also a very well tolerated drug. So since we're talking about tolerability, I wanted to spend a little bit of time talking about the side effects that we typically see with BTK inhibitors and some sort of tips and tricks for how we can approach managing them. First, I'll highlight that CLL patients very commonly, unfortunately, have a lot of symptoms and complications that I think in many cases are due to the CLL disease itself rather than to the treatments. And I think this is illustrated nicely by a study that's ongoing in Europe right now called CLL-12. This is a study that took CLL patients who had higher risk genetic markers but did not require CLL treatment at the time of the study. And they got randomized to an early intervention strategy where they received ibrutinib before they would otherwise normally get treated, or a placebo. And in terms of the rate of side effects, 95% of the patients on ibrutinib had a side effect. But if you look at the placebo column, 95% of the patients with placebo also had a side effect. So presumably that's not being caused by the placebo, it's being caused by the CLL. Now you do see a little bit higher rate of those worst side effects, grade 3 or higher, about 50% with ibrutinib compared to placebo. And in terms of the different side effects that they saw in the two arms, they were a bit different. So there were some cardiovascular issues with ibrutinib compared to placebo, and about twice as many patients had to stop treatment with ibrutinib compared to placebo, suggesting that there are, of course, side effects with ibrutinib. And so there is a cost to starting therapy early in terms of the side effects. And so based on this study, we are not recommending early intervention before the traditional treatment indications are met. But I do think it's a helpful study to help us understand how many different side effects patients can be having from the CLL disease itself. The other thing I will say about ibrutinib is that the side effects that we see do differ a bit depending on the age of the patient and what other medical conditions they have. And a nice illustration of that is a comparison of two different studies in CLL. These are all previously untreated patients, but the study done by a group called Alliance looked at older CLL patients. So the average age in the patients on this study was 71, and patients were up into their mid-80s when they started treatment. And they compared their data to a study by the ECOG group called E1912, where the average age of the patients was 57. So this is a pretty young population of CLL patients, and the oldest patient on that study was 70. And kind of comparing across these data sets, you can see infections were much more common in older patients, 19% versus 5%. The rate of atrial fibrillation was twice as much, 6% versus 3%. There was more bleeding and high blood pressure. So, I think this does speak to the fact that particularly for younger patients who are fit, ibrutinib is still a great option to consider. But as patients do get older and have other medical issues, thinking about the other BTK inhibitors that have now been shown to have fewer side effects, I think is an even more important consideration. So what are some practical issues around side effect management with BTK inhibitors? One thing to note is that sometimes patients can get very low platelet counts. And we do think that in that setting, because the platelets also help you clot your blood, that there may be a higher bleeding risk when you're on the BTK inhibitor drugs. So you do need to be mindful of that. If you have a very low platelet count, you may want to talk to your doctor about whether you need to stop the BTK inhibitor drug, at least for a period of time. The other thing that's very important is that if you're on any of these BTK inhibitor drugs, that you need to stop taking them around the time of different procedures. And some rough guidelines that I like to use for cataract surgery, which is a fairly bloodless procedure. Actually, some ophthalmologists don't even require us to hold the ibrutinib or acalabrutinib or zanubrutinib at all, but I usually recommend stopping it for 1 day before and after the procedure. For something like a colonoscopy where there may be an intervention, a polyp might be removed, there may be some bleeding risks, I usually recommend stopping for 3 days before and 3 days after the procedure. And for more significant surgery like a gallbladder removal, there I'd recommend stopping 7 days before and 7 days after the surgery. Of course, every case is different, and so please consult directly with your oncologist about what would be best for your particular situation. But these are just some rough guidelines, not medical advice. Occasionally, unfortunately, patients have accidents. Car accident, they might need emergent surgery where they get rushed into surgery. And if they're on a BTK inhibitor, that's a situation where sometimes a platelet transfusion can be helpful to reduce the risks of bleeding. So it's important for your providers and your family members to know if you're on a BTK inhibitor and to be aware of these risks of bleeding. With cardiovascular disease, it can sometimes be difficult to control blood pressure on BTK inhibitors. There's also atrial fibrillation. And so sometimes partnering with a cardiologist can be very helpful to provide additional support and recommendations for your oncologist. If you have an active infection, that really is another situation that really needs to be individualized. But generally, if I have a patient who has a more severe infection, I will hold the drug. I'll have the patient stop taking the BTK inhibitor drug to help control the infection, because these drugs, although well tolerated, do suppress your immune system a bit. And then there's something called autoimmunity, where your immune system, because of the CLL, can attack various parts of your own body, including blood cells. And sometimes when we're using BTK inhibitors, we can see that flaring and getting worse when we first start the drugs. But eventually, as we achieve longer-term control of the CLL, that tends to improve with time. Other things to watch out for on BTK inhibitors. So if you're on a BTK inhibitor and you have a blood clot or some other reason why you need to be on an anticoagulant, that is definitely a major decision and needs to be discussed with your physician. We try to avoid anticoagulants if possible. However, it is generally safe to use the anticoagulants with the BTK inhibitors. We tend to use what's called DOAC therapy, which is direct oral anticoagulants, instead of warfarin or Coumadin, which is an older drug that can lead to more unpredictable levels in the blood. The DOACs are pretty predictable. And so if you need to be on an anticoagulant and a BTK inhibitor, you need to be very careful to avoid bleeding issues, but it can be safely done with the DOACs. We also try to avoid what we call dual antiplatelet therapy. So one of the antiplatelet drugs is aspirin, which is pretty commonly taken. And there's another drug called clopidogrel, or Plavix is the brand name. And sometimes that's used in people who have cardiovascular issues. And we try to have patients not be on both of those if possible while they're on a BTK inhibitor. And then there's other drugs which can interact with the enzymes in the liver that process BTK inhibitors, the so-called CYP3A inhibitors. These can be drugs or they can be foods. So certain things like grapefruits, grapefruit juice, star fruit, we try to avoid those. Some antibiotics, as you can see here. If you need to be on certain drugs, you can sometimes reduce the dose of the BTK inhibitor and do that safely. Often it's helpful to get a pharmacist involved to help advise the oncologist on how to do those dose reductions. So just some other general considerations around how to manage side effects with BTK inhibitors. As I mentioned, with active infection, it's generally best to hold the drug or stop taking it, at least until the infection starts to improve. In general, I would say for most side effects where we do have to stop the drug, it's preferable to try to re-challenge later with the full dose of the drug, because often it's kind of a one-time thing. You can hold the drug for a little while and then restart it at full dose, and patients can do very well. Or if you feel more comfortable starting back at a lower dose, that's fine. But I do encourage patients at least to try once to get back to the full dose, just because the best long-term data we have with these drugs is with using the full dose. And so if we want to be able to replicate the great results we've seen long-term in the studies, then we want patients to be on full dose whenever possible. That being said, sometimes it's not possible, and certain patients process different drugs differently. So for certain patients, staying on a drug at a dose reduction is a very reasonable strategy. One general principle is that I'm more hesitant to have a patient stop taking a drug because of a side effect very soon after they've started the BTK inhibitor. or if there's a patient who's been on a BTK inhibitor for a while and their CLL is starting to get worse, I'm very hesitant to hold the drug in that setting. And the reason is that in both cases, when there's a lot of CLL around and you stop the BTK inhibitor, you can see a flare of the disease, meaning things actually get worse. The CLL starts to grow very rapidly and patients can feel poorly. So, if there's a very minor side effect, I will try to continue the BTK inhibitor in that setting. Sometimes you're forced to stop it because of a more severe side effect or the need for surgery, and then you try to monitor patients closely to get them through that time. Now, in contrast, I'm less concerned about stopping these drugs in patients who've been on BTK inhibitors for at least a few months or longer and are in a good clinical response. And so, sometimes I have patients who are worried, they've been on BTK inhibitor 3 or 4 years, they need a surgical procedure, and they're concerned that if they stop it for a couple weeks, their CLL may come roaring back. And that's just very unlikely. Patients who are in a good response can often safely hold the drug for a couple weeks or even longer if needed and continue to do very well. The other thing I see that's a common misconception is that people think that the BTK inhibitors are causing low blood counts like anemia or low platelets. I think that's generally not the case. One thing is that these drugs, the BTK inhibitors, tend to work a little bit more slowly on the bone marrow, which is your factory for making blood cells. And so sometimes early in the course, patients can have anemia or low platelets because the CLL is still there in the bone marrow and not allowing production of the normal cells. And so I often just encourage patients to really stick with these drugs. In the long term, it continues to chip away at the bone marrow disease, and eventually the counts do improve. Neutrophils can go down on these drugs. We do see that. I mentioned that with a few of the studies, and it's generally safe to give these growth factor shots at the same time as the novel drugs. This is like GCSF products, like Neulasta, for example, is a brand that you may have heard of. And often we can keep these drugs going as long as we give the growth factor support at the same time, and that allows us to keep the neutrophil count up in a safe range. And the other point that's very important is that if you've had to permanently discontinue a novel agent drug like a BTK inhibitor because of a side effect, it doesn't mean that you necessarily need to start on a new treatment right away. And so this was looked at in one of the studies of ibrutinib, where patients had been on ibrutinib in general for a year or longer. And if they had to come off because of a side effect, those patients were not immediately started on a new therapy. And on average, they went close to 2 years before they needed to go on a new therapy. So you may have a window of opportunity to be off treatment again. And then when the CLL does eventually start to progress, you can go on a new therapy at that point. I also like to emphasize that we try from our provider side to optimize oral therapy adherence. And I do view this as a shared responsibility between the clinician and patients. So, we write the prescriptions, the patient fills the prescription at the pharmacy, and then we really rely on patients to be administering the correct dose of the drug at the correct time of day. We rely on patients to communicate and let us know if they're having these adverse events or side effects. And it's really only through this kind of two-way communication that we can help patients to tolerate the drugs better, to stay on track with them. And we've seen that does lead to better outcomes. I give one example here from a study called Resonate, which was with ibrutinib. And we did see that patients in that study who missed 8 or more consecutive days, other than holding it for surgeries, but if they had to miss 8 or more consecutive days of the drug because of side effects, they tended to have a shorter duration of their response to the treatment. And in general, patients with a higher dose intensity, meaning taking the drug on a regular basis at the proper dose, did have longer time on drug, a longer benefit. And so this is definitely an important thing is to be able to stay on the drugs as long as you can tolerate them. All right, so that was a lot of data, a lot of information. I wanted to kind of take things back to the key takeaways right now for BTK inhibitor therapy in CLL here in 2022. So first, BTK inhibitors really are now a mainstay of therapy in CLL. If you look at the most commonly used therapies here in the US, the BTK inhibitors are number one right now in terms of use. And ibrutinib has been used very widely over the last several years since its approval. And it's a great drug, but we have seen, particularly in older patients and those with a lot of other medical conditions, that up to 20% or more of patients will have to stop ibrutinib because of side effects. And so we're excited now to have this next generation of BTK inhibitors that seem to have similar levels of controlling the CLL compared to ibrutinib, but are clearly associated with reduced cardiovascular complications, especially atrial fibrillation, as well as a reduced risk of other side effects. And so these drugs like acalabrutinib, which is already approved in CLL, and zanubrutinib, which is coming soon for CLL, are great options for patients with this disease. Now, with all of these older drugs, we are starting to see these resistance mutations arising. So I think there's a lot of excitement now around the reversible BTK inhibitors in development, like pirtobrutinib, which may actually help to overcome the resistance mutations. And then we focused at the end on some of the common side effects of BTK inhibitors that can occur, but are generally quite manageable for most patients. So I do always like to emphasize that with all of the rapid evolution in the field of CLL with BTK inhibitors and other drugs, that active participation in clinical trials really remains critical to help us understand how better to optimize therapy for our current CLL patients today, but also for our patients with CLL of the future. So with that, I'd like to thank you very much for your attention, and I'm very much looking forward to questions and answers. Thank you.
Dr. Davids, that was amazing. Thank you. That was so clear and a very in-depth look at that. I sure learned a lot from it, and I think so did our audience. We have a ton of questions, and I know that you have a pretty tight deadline here in terms of another meeting right after. So let's see if we can get to as many as we can. I will say that if we can't get to the questions, send it to Ask the Expert email address that'll appear after this. It's also on our website, and we'll try to respond in that way. So I've got a bunch of, so let me just start with a real basic question. Somebody asked, there's a rise in the absolute lymphocyte count. They've been on the meds for a long time. Their counts are higher than when they started. They feel fine. The nodes have shrunk. Tell us a little bit about that.
Yeah, so first, thanks so much for having me, Brian. It's always great to interact with you and to be able to speak with so many patients at once. So it's an honor to be with you. So, I think with lymphocytosis, which is the rising lymphocyte count on a BTK inhibitor, one of the key things is the time course of when that's happening and also how quickly it's happening. So just to be clear, this is expected when you first start on a BTK inhibitor. We expect that lymphocyte count to come up and then eventually to go down. But what you're talking about, I think, is a patient who's been on a BTK inhibitor for a long time. The white blood cell count, lymphocyte count has been low, and now it's starting to trend back up. So if it's trending up rapidly, that is concerning, and that's probably a patient who's going to be headed toward needing more treatment, switching treatment soon. But we have many patients who kind of have this very slow rise of a lymphocyte count while they're still on the BTK inhibitor. And sometimes that can go on for months or even longer, a year or 2 years, and patients can continue to do well. So the one thing you don't want to do in that situation is just stop the BTK inhibitor cold turkey, because when you're having some progression already and you stop the BTK inhibitor, you can have a flare of the CLL. So it can get a lot worse quickly and patients can get very sick. So really the key is to stay on the drug, have a good conversation with your oncologist about the timing of when you want to switch treatments. You don't have to wait until you have a huge burden of disease in terms of big lymph nodes or big spleen. But I usually like to wait to see something else besides the lymphocyte count. So maybe it's the lymph nodes are starting to grow, or you're starting to develop some anemia or low platelets, and that's a good time to think about making a switch.
And let's ask if it's early on and you go in and you're mainly going in because of symptoms. You're having B symptoms like fatigue, or you've got painful nodes, and they've all shrunk, but your count, which maybe started at 60,000, went up to 120,000, and it's now 10 months later and it's 110,000. It really hasn't moved very much, but you're feeling great. Your nodes have all shrunk. What do you say to those patients? I've certainly seen patients where it's been 2 or 3 years before their counts got back to normal. Does that mean anything?
Yeah, you're exactly right. And my advice in that situation is be a patient, because these things can take a very long time to resolve. And one of my colleagues at Ohio State, Jennifer Woyak, did an interesting analysis a few years ago where she looked at patients on ibrutinib and compared those patients who had a very long-standing lymphocytosis, high lymphocyte count for months or even years after starting ibrutinib, compared to those patients who had very quick resolution of the lymphocytosis. And she looked to see if those patients sort of had any differences in terms of how long they benefited from ibrutinib. And it turned out they did not. So it really has no influence on how long you should expect to be on the drug. And so really just reassurance is all you need at that point.
You mentioned one of the most serious adverse events, and I'm going to go after two of them, is the first one is cardiac. Is there any screening that you recommend, especially for your older patients? I've read some articles where looking at the EKG parameters may be predictive of who's likely. What practically do you do for patients when you're considering a BTK inhibitor in someone, in that older age group where it's more of a risk?
Yeah, I do generally like to get a baseline EKG just to look for any warning signs, or at least to have a baseline such that if something does develop, I can then compare back to where I started. I don't tend to get more investigations beyond that, like echocardiograms or stress tests or things like this. I think that I tend to choose a BTK inhibitor that has a better cardiovascular safety profile in a patient like that if I'm going to use that class of drug. Or if I have a patient who I'm very concerned about, if they have severe cardiac disease, I'm going to try to avoid BTK inhibitors and maybe use a venetoclax-based treatment.
So there's no one go-to test. If you pass this test, you're okay. It's just kind of a judgment. And sometimes getting the cardiologist involved can be helpful too, I think. Yeah. What about the infection risk? Do we know? It seems like there's this infection risk, and let me higher, especially early on. I read some data where ibrutinib, the infections were higher in the first couple of years, and then they seem to get better after that. And what about COVID now in terms of these medications, their risk, their response to the vaccine? And if somebody does get COVID, you take them off their BTK inhibitor. So a lot of questions around infections. Yeah.
Yeah, a lot of questions in there. I'll try to unpack that. So, I think in terms of the first aspect of just infection risk in general in CLL, we know that that's high even in patients with CLL who are not on therapy. So there's definitely something about the disease itself which increases the risk of infection. And in terms of different treatments that we have, probably at least initially when we're starting these treatments, there is some additional increase in risk of infection beyond the baseline risk of the CLL. And I think BTK inhibitors are certainly part of that as well. One of the things about BTK inhibitors is, at least in terms of sort of overall disease burden reduction, they don't tend to work that quickly. So even though the lymph nodes may shrink quickly, as we just discussed, that white blood cell count can stay high for a while. Bone marrow disease tends to kind of be slow to go away. And so in that critical period, particularly in the first few months, when you have some sort of impairment of the immune system from the drug, plus the CLL is not that well controlled, I think that's when patients are the most vulnerable for infections. But one of the things that happens, we think, is that as the disease becomes better controlled, as you get to sort of 6 to 12 months and beyond 12 months on a BTK inhibitor, even though you're still on the drug that can suppress the immune system, the CLL is in such a good remission at that point that the effects of the disease are less. And so overall, the immune health is better. So that's kind of the window of time, I think, especially in that first 6 months or so, up to a year, where patients are most vulnerable for infection. And, we could spend an hour on COVID, but, I think sort of just to keep it simple, we have not taken an approach of stopping BTK inhibitors for patients who develop COVID infection or around the time of vaccinations, simply because we don't have any data to know whether that's a helpful approach. For all we know, it could be a harmful approach. We had some early reports suggesting that the BTK inhibitor drugs may actually help to mitigate or lessen the inflammatory effects of COVID. And so maybe there's some benefit to keeping patients on the drugs if it's a mild COVID infection. I would say if patients get very sick with COVID, if they're hospitalized or certainly in the ICU, we would stop them at that point to really try to maximize immune response.
So let me go after the other adverse event that hits a lot of patients, and that's the financial toxicity. And I wonder if you want to comment on that. And, one patient asked about, there's the PAN Foundation, and LLS has generous programs, but they run out of funding. Are there any advice you have for patients, or how do you help a lot of because this is often patients who are on a fixed income, Medicare, you go through that donut hole. This stuff is expensive. All of them are expensive. Any bright lights in the future that you see, generic versions, or any tips you give your patients on this?
Yes, certainly a challenging area. We're lucky at a big center here that we have a whole team of pharmacy people who help patients with this. And so as soon as we send in the prescription, we have navigators and people who are looking into assistance programs. So you're not on your own. If you're in a smaller practice, you may not have access to someone like that. So, partnering with others in the practice as you can, and you might need to do a little more of the footwork on your own. If you're a younger patient, if you're not on Medicare, there are often company-based assistance programs that you can apply to. And so most of my patients who have commercial insurance who are younger don't have too much difficulty getting support there. I do think the bigger challenge comes from the Medicare patients because the companies can't provide direct support. So as you say, there's foundation supports, but a lot of those are sort of financial, need-based, and a lot of my patients who aren't enormously wealthy, but can't afford thousands of dollars of copay per month, kind of get stuck in the middle there, especially when they're in that donut hole period. And so it can be challenging, especially year after year, having to come up with these copays. And so that's one of the reasons why we are working on developing more time-limited regimens where patients can have a deep remission and then hopefully stay in remission for years off therapy. I think that will be helpful for the financial side. My understanding of the sort of prospects for generic BTK inhibitor is don't expect that anytime soon. My sense it's many years away, actually, unfortunately. So that will be helpful eventually once we have generic BTK inhibitors, but not in the near future.
Let me touch, and there's a whole area about making BTK inhibitors limited duration therapies. So let me start with a bunch, and then you did a nice job of unpacking last time. So I may throw a bunch of questions here because we're not going to get to the 64 questions that were sent in during this and the dozens that were sent in before this even started. But what about using MRD that guides other therapies? What about cocktails? You mentioned using the antibodies, but there's a lot of interest in using it with venetoclax. And I know you've done some research using it with chemoimmunotherapies to make it limited duration. So let me start with that. Do you ever see MRD with the BTK inhibitors? What about adding in other drugs? What about going to a limited duration with the BTK inhibitors?
Yeah, so these drugs were all developed as continuous treatments when given as single agents. And so a question I sometimes get from patients who've been doing well on a BTK inhibitor for 2 or 3 years is, can I just stop at this point? And I really don't know how to counsel patients on that because I don't have any data to know what happens really. Maybe a little bit of limited data we could discuss, but I think the strategies that you're mentioning are probably more promising than just stopping a BTK inhibitor. And that's trying to get to the minimal residual disease undetectable state through a variety of different combination methods. And with BTK inhibitors alone, we almost never see undetectable MRD. When we add in the CD20 antibody, at least with obinutuzumab, depending on the study, we might get up to about 40% of patients into undetectable MRD. So I think that's interesting. I think one of the studies that my colleague Anthony Mato is running now at Memorial Sloan Kettering is actually looking at that approach of time-limited BTK inhibitor, acalabrutinib with obinutuzumab for patients who get to undetectable MRD. So I like that type of trial to see how that works. But probably the most widely studied right now is the combination with venetoclax, whether it's ibrutinib venetoclax, which is likely to become an approved regimen soon, or acalabrutinib with venetoclax, which is also in development a little further behind. I think the majority of patients are going to be able to get into an undetectable MRD state with those types of combinations. And then the question is going to be sort of how durable is that? If you need 2 years of therapy with pills and you only get a year or two of treatment-free time, I'm not sure if that's worth it. But if you can do a year or two of therapy and be off treatment for 4 or 5 years or longer, then we're really talking about something there. And I think that could be very valuable for patients, not just in terms of keeping costs down, but also the side effects certainly are less when you're off therapy, and also just not having to be reminded of the CLL on a daily basis, taking pills.
We talked a little bit about resistance. When do you tend to see that? Is there anything that predicts when that resistance will develop? Is it an early phenomena, a later phenomena? Is there anything a patient can do to prevent it? Is there anything that gives you a little bit more concern that this is a patient you're already thinking of what your next move post-BTK is?
So fortunately, resistance mutations are quite uncommon for patients with CLL, especially in the frontline setting when they're getting a BTK inhibitor as their first therapy. The one factor that we know can predict for that is the TP53 mutation or deletion 17p. That that certainly increases that risk. And that being said, we still will use these drugs, but we expect as we sort of get to 6-7 years on frontline therapy, the average patient may develop some resistance by that time frame. And we can actually start to detect these mutations in BTK that confer resistance even before we see evidence of clinical disease progression. Right now, we don't really know what to do with that information, so it's not something we recommend routinely, but we're kind of doing it in the research setting with the hope that maybe someday if we could have early detection of resistance mutations, we could change the therapy in some way to maybe reduce the risk of clinical disease progression. So there's really nothing that patients can do at this point to reduce that risk. We do think that, at least based on the data we have, staying on the drug long-term is important. So you don't necessarily want to be on and off drug frequently. Sometimes you need to be if you have to have a procedure or something like that, that's fine. But in theory, if you're off and on the drug frequently, it could increase the risks of resistance arising.
Yeah, we know that in a sister cancer, CML, that it's lack of adherence, lack of taking your medications is the leading cause of resistance. People stop taking their oral Gleevec, imatinib, and that's the leading reasons people become resistant to it. So we suspect that the same thing might happen in CLL long term. We don't have that. If you've gone off the BTK inhibitor for whatever reason, could you just elaborate on when you would start therapy again? Is it you enter watch and wait or active observation again, or just say, this is going to bounce back? Could you elaborate on that?
Yeah, so I sort of alluded to this before, but maybe I'll go into a little more detail. The best data set that we have from this is from a study called ECOG 1912, which looked at younger patients and compared the patients treated with FCR, the older chemoimmunotherapy, to an ibrutinib-based treatment. And in that study, there were close to 100 patients who had to stop ibrutinib because of side effects. And then they followed those patients out over time to see how they did. And it turned out that they went close to 2 years from the time that they stopped ibrutinib until the time that they had progression of the CLL. And so, for that reason, if a patient does have to stop a BTK inhibitor because of a side effect, I do usually like to put them back on the watch and wait. And maybe we'll get a couple years, maybe even longer before we need to start a new treatment. And, in terms of the indications to start that treatment, it's pretty similar to what the original indications were. I might have a little bit of a lower threshold in terms of restarting. Maybe not let the lymph nodes get quite as large, or the anemia get quite as significant, because that patient inevitably is going to need more treatment. But yeah, that's sort of how I approach it. Is kind of similar to the watch and wait initially.
We're down to 3 minutes. Can you stay 5 minutes after?
Yeah.
All right. Yeah. Well, I'll let you go after that. Sure. Dosing seems to be an issue, and you talked about dose reduction and that not being preferable. With ibrutinib, that seems easy to understand. What about with acalabrutinib, where it's 2 pills, you'll have to half the dose? Is there any advice you have if a patient's having an adverse event about reducing that dose? And also, somebody asked about proton pump inhibitors and acalabrutinib, and I don't know if there's any data at all on zanubrutinib in reduced dosing.
So there's not as much data that I'm aware of for either acalabrutinib or zanubrutinib with dose reduction as compared with ibrutinib, where we have a lot of robust data around that. But I would say in practice, if we need to dose reduce acala, for example, I mentioned that headache is a little more common when patients start. Usually we can manage that with Tylenol, caffeine from coffee, et cetera. But I've had a couple of patients where I've had to dose reduce the acalabrutinib, and I'll go down to 100 once a day instead of 100 twice a day. And that can often be helpful. But because there's more uncertainty about how effective that's going to be, I then try to re-challenge patients and go back up to the full dose when I can. If the same side effect occurs again, then you may just back off and go back to the lower dose and hope that that's as effective. And I think that, as I mentioned in the talk, people's bodies process these drugs differently. Some people may get that lower dose and have just as much drug in their body based on how it's processed compared to someone else. So I think we need to use common sense and our clinical judgment to help patients manage these side effects.
All right. I think we're going to have to stop there because I wanted to give you a few minutes just to, I'm going to disappoint people because I didn't get to questions. Let me just ask you one curious non-BTK question. And this is also, I have this issue. Monocytosis, elevated monocytes. That seems to be a common issue in CLL. Is there anything that you can comment on that, or is that just a weird thing, an idiosyncratic thing that doesn't mean anything?
Yeah, I think in the modern treatment context, I wouldn't put too much stock in that. One situation where we used to see that back in the old days when we were using chemoimmunotherapy is when you knock the blood counts down and patients have very low blood counts from chemo, their neutrophil count can be very low, and you actually start to see monocytes coming back first. So that was always sort of our initial clue about count recovery, and then a couple days later, the neutrophils would come back.
Right.
But because these newer drugs don't really cause those levels of suppression of the other cells, monocytosis is not something that I've really seen as a common pattern. I've seen a couple of situations where it's there, but it doesn't seem to have any clinical significance.
And I'll finish with pirtobrutinib. Can you comment on its action in 17p deletion and whether you see it eventually being used frontline? I know it's very early, but just this would be more speculative. Yeah.
Yeah, I mean, based on the data we have so far from pirtobrutinib, it seems to be very active both in the non-17p, but also the deletion 17p population, also in patients who have the BTK resistance mutations and those who don't. And even in patients who've had both the traditional covalent BTK inhibitors and venetoclax, and pirtobrutinib can still be very helpful for many of those patients. And so between the activity of the drug and then also the fact that it seems to be very well tolerated, I'm definitely excited about the data that we've seen in the relapse setting. And we haven't seen any sort of treatment data in the frontline setting yet as a first therapy, but the company has launched studies to look at that. And I think if the data look similar to how they look in the relapse setting, I think it's going to be another great option for patients.
So, Dr. Davids, any final thoughts or messages you want to pass on to this large audience that's been very interested in BTK inhibitors? And this was a deeper dive than just a superficial kind of look saying they're great. I really appreciate it. Any final thoughts you wanted to share?
Yeah, I mean, again, thank you for having me. It's really a privilege to be able to reach such a wide audience and to be with you, Brian, because you inspire all of us to work hard and do better for our CLL patients. And I would say, my closing thought would really be for all patients that you should consider enrolling in a clinical trial. It doesn't mean it's right for everyone, but you should consider it. We have a lot to learn still in CLL, and sometimes I feel like people think that clinical trials are a last resort. But it's really the opposite. Clinical trials are often our first best option. It's our best educated guess as to what the greatest next therapy is going to be. And we think that it's really important to continue to make these advances, not just for our current patients today, but for patients in the future. And so that's a major contribution that patients like yourself who've been on clinical trials have already made to the field. And it's an opportunity for patients out there to make a similar contribution to the field and for their fellow patients. And so if you don't have a CLL expert who's involved with your care, I think it's great to have someone like that on your team. I know that's a big message from the CLL Society, but I fully endorse that. And even if you're being treated locally, many of us are around, we're able to help and advise as to the best steps. So that would be my final message.
Yeah, thank you. I so echo that. I think it's really important to put your team together. If you can have an expert on that team, great. If not, you can have a local expert that consults with an expert at a place like Dana Farber or UCSD or Ohio State or MD Anderson. There's, but you don't need to be seeing them on a regular basis. Putting your team together is critical. And I'm alive today because of clinical trials. There's no question that if I hadn't enrolled in a phase 1 trial of PCI 32765, which later became ibrutinib, I wouldn't be around. I had 17p deletion, chemo wouldn't work for me. I'd failed a bone marrow transplant. And from there, I went on to a CAR T trial of JCAR014, which was sort of the grandparent to liso-cel, which hopefully it's a CAR T therapy, which hopefully will be approved soon. I was also on a trial of AZT7442, which later became Evusheld. And I was lucky enough to be in the active arm of that. Didn't know that until later. So Dr. Davids, thanks so much. This has been incredibly helpful. I do want to again thank you to our sponsors, AstraZeneca, Beijing, Janssen, and Pharmacyclics for making this event possible through their support. I want to thank everyone for joining us today. And this is and sharing their questions, and Dr. Davids for his unique expertise. There's a couple events coming up. Let me remind you that there's going to be a survey afterwards. Please complete that survey and give us your feedback. We need that to do better. We need that bluntly to let our sponsors know how we're doing, what's going on, what you liked and what you didn't like, so we can improve. We listen to that. We read every single comment. We have something exciting. Maybe I can get you, Matt, involved in this. Our 5K walk run event. It's our first peer-to-peer fundraising that we'll be doing. It's going to be really exciting, and you can do this virtually. You don't have to meet with people if you're worried about a COVID surge in your community. You can just, and we're not going to be having a tape measure out to see if you actually did the 5K. The important thing is to have fun and to raise the funds. Dr. Mazyar Shadman will be doing a session on CAR T therapy out of the Fred Hutch. Dr. Shadman is one of the leading cellular therapy experts in CLL, and he's also a great educator. So that's going to be a wonderful event. Make sure you register for that. And then later in the year, we have a COVID event. We have our Facebook Live event. That's our next coming up event on July 7th. There'll be details on the website. I'm doing that with Michelle Nadine. So that'll be really exciting. So just remember, the CLL Society is invested in your long life. Please invest in the long life of the CLL Society by supporting our work. And thank you all. And we finished pretty much on time.
Thanks so much.
Thank you.
Bye.